Well, welcome everybody. So I'd like to keep this fairly informal tonight. And as Amy said, I'm one of the professors, do a lot of teaching with the residents and stuff like that. So I'm kind of used to giving talks and used to going through things like this. But what I laid this out to be is just a few slides about explaining what a plastic surgeon does, what we are, what we go through in training. And then at the kind of the mid portion there, we don't have too many slides, but at the mid portion I'll go into some clinical cases. So anybody that's a little squeamish, I'll give you the warning in case you want to not look at some of the slides. But I did bring some intraoperative slides and things like that too that might be kind of interesting for people to see. So I'll just let you know if you want to not see those kind of things, we can switch. We can gloss over them or skip them altogether if you want. Yeah. They're not too bad, but they're kind of interesting. It kind of gives you an idea of the extent of what we do more than anything else. So anyway, that having been said, we should have plenty of time for questions because I like to leave it open. Usually you guys have quite a few questions about, that these talks kind of generate and stimulate some interest and things like that. So we'll go from there. Let's see. Now, see if I can figure out how to use this thing. That's the pointer. There we go. So like I said, we'll describe the diverse nature of plastic surgery. We'll review the training and certification requirements that plastic surgeons have. And also we'll describe some of the patient safety and quality initiatives that we've been hearing a lot about recently and what we're doing in plastic surgery to kind of meet up with those. And then we'll demonstrate the examples. So, different plastic surgeons, one of the reasons I got attracted to plastic surgery so much was the diversity of things that you can do. And some plastic surgeons like myself like to keep things kind of broad and do a lot of these different things that we have here. Other plastic surgeons like to narrow it down into just doing what we call lumps and bumps and breast reductions and those kind of things. My former partner, when I first started, I actually started in private practice with Dr. Collins, and that was essentially his entire practice was more of a dermatology-based skin practice where he did that, a little bit of cosmetic and breast reductions, and that was pretty much what he did, and he kept it very, very focused and very good, and that worked for him. It made me extremely bored, which was one of the reasons I ended up in academics doing some bigger things like that. But it all depends on what the individual plastic surgeon really, how they want to focus and streamline their practice, and it very much does become an individual thing with each individual plastic surgeon. But we have a lot of overlaps with other specialties too, and so we get to interact with a lot of different specialties. So it's not just cosmetic surgery and skin cancer, but we also do breast reconstruction, hand surgery, pediatric plastic surgery, which I'll show you some of those cases, microsurgery, and then burns and trauma reconstruction, or some of the things that we do. So there are two pathways to becoming a plastic surgeon, and one of those pathways, of course, you have to finish and complete medical school in an accredited institution, and then after that, I went through general surgery and completed all of general surgery because back in the early 90s, almost all of the programs did that. There were very few that took trainees right out of medical school. That was sort of something that developed in the 90s and really took off after the year 2000 when they started focusing more on less general surgery, less training that didn't really focus on the core specialty procedures and those kind of things. But I completed and got board certified in general surgery before I took my plastic surgery training. But you can also be an orthopedic surgeon. The director of the orthopedic department at UPenn used to be the director of the plastic surgery department at Duke. So there's some of those specialists are overlapped between that. There's not too many urologists that I know of. I know that the program director at Yale is a neurosurgeon, actually. Started out as a neurosurgeon and then became a plastic surgeon. So there's a lot of diversity in the group. And so after you complete that general surgery training or that entire course of training, then you have to do another 3 years of plastic surgery. So that ends up being 8 or 9 years of training to go that pathway. This is all after medical school. The next, and then what's been the recent training, the trend though, is to just take residents right after medical school. And so you have them for a full 6 years as your trainees, and that's the program that we have here and the one that Claire's interested in doing too, as one of our med students. So that way we have them for a longer period of time. We get to see their progression, plus we can focus more directly on plastic surgery training. And some of the reasons why that's become, there's a lot of reasons why that's happened. It's happened in vascular surgery and thoracic surgery as well. And the concept is that there's fewer of some of the more what we call index cases in general surgery, so we don't want to train plastic surgeons and take away, like say for instance, pancreas operations and those kind of things from general surgeons who may be actually doing those surgeries, when plastic surgeons are never going to do a pancreas surgery once you finish your general surgery training. So that's the part of the reason for that has been just the refocusing on index or important cases that there are not quite as many of as there are in terms of operative experience. So anyway, those are the two pathways. One is called an independent pathway, which is where you go through all the general surgery training and those kind of things, and the other is an integrated pathway where we do take them right after medical school. And that's our program here, is we have them for 6 years right after medical school. And we have one resident per year here at Wright State. So after you complete your residency, you have to take a written exam to be able to sit for the board certification process. And it should be noted that there's different kinds of boards, and you hear a lot of different boards that are out there. The boards that really matter are the ones that are accredited by the American Board of Medical Specialties. So there's an overseeing body that looks at all the recognized specialties, because there are boards out there that you can pay $75 for and get a certificate and they'll call you board certified. But they're not really recognized by the American Board of Medical Specialties. And so that gets a little bit confusing to the public about what board certification actually means. Board certification in plastic surgery, actually, this is kind of the whole process. Not only do you have to complete medical school and the residency program, but then you go through a process of them kind of evaluating your practice and how you're going to actually do in the future. So what you have is a written examination, which is technically called the qualifying examination, and that's taken usually in the fall right after you complete your residency training. And then after that you go through a case collection period, which is usually about 9 months now, and it goes usually from September to the next July. And what that means is you have to track and record every single operation you do, and every single major patient that you see. If it's a burn patient, even if they don't require surgery, you have to track those patients too. And you put them into a database that monitors their outcome, not only their outcomes, their diagnosis, what operation you did, whether or not they had a complication, but also you have to record what bill you sent in too. So they actually look at everything and they look at it in detail. And so then you go to your oral examination, which is usually in the fall of the following year. And what they do from that is they'll give you a set of unknown cases where they'll show you pictures or give you a clinical scenario. And you're in there with two very well recognized plastic surgeons from an area where you don't know. So it's not somebody who you know, it has to be somebody who is in a different institution. And then they'll give you some unknown cases, and they'll grill you for about 2 hours on that, maybe a little bit less. And then actually you go out of the room, you go into a separate room where there's another set of two plastic surgeons who will go over your own cases, the cases that you submitted to the board. And they'll pick, out of all the list that you have, they usually pick about 8 cases that they'll go through, and you have to prepare a whole book of everything in addition to the database that shows the photographs and everything of the patient. So you have to have all that. It's really a detailed process about becoming a board certified plastic surgeon. And then after that, the fun is not over because you get to, now your certificate used to be for 10 years, but now everybody's entering into a maintenance of certification program. And we have to do this every year where we do updating of our certification. And there's different things that you have to do in the process of that, but it has to do with every few years you have to take an examination, you have to submit your CME that you do, which is 150 hours every 3 years plus, and we'll get into this a little bit later, but there's patient safety requirements in what we do for CME also. So this is all part of the process. Interesting thing that we see is most of the failures that are coming around now, probably at least half of the failures from the board examinations come on the basis of ethics, which is kind of interesting. And when I say that, usually by the time people have gone through all this training, they're pretty good surgeons. They do a pretty good job at taking care of patients. Most of the people that fail actually end up failing because of ethics. And the reason for that is, and we had this situation show up in some people that I know a couple of times, and what it is that people tend to, young graduates tend to go to places like California where there's a lot of competition, and therefore they don't get regular patients in, so they really need to, they don't get as many because there's so many plastic surgeons in a certain geographic location that they decide to do. So they tend to either upcode a procedure or something like that, and so that they really get dinged on the coding, and that's where they fail. So it's really usually not on patient safety or patient care, but it's usually on stuff like that. And the board's very, very particular, and they really get come down hard on people for ethics and coding. And coding, for those of you that don't understand, does everybody know what coding is? So in the process of sending a bill in to the insurance company or anything, you write down not only a diagnosis code but also a procedure code. And that procedure code, there's a whole list of codes that are in a book, and the procedures listed next to the code, and that's how it gets sent in for the bill. And so what ends up happening is that if you say, for instance, and there's different levels of repairs. Let's say, for instance, if an example would be if you just repair skin, then that's one code, but if you repair skin and the deeper tissues, that's a different code. Well, some people will upcode to a deeper level tissue repair, or they'll say I did a local flap when it was really just suturing the skin together, those sort of things. So it's something to be very careful about, especially, we always try to be careful, but there's a lot of ethics and coding that goes into that, and and that happens in a lot of medical specialties too. Anyway, enough of that. So patient safety. So there is a required component of CME, and right now it's only about 20 hours per cycle, which doesn't seem like a lot. But all of the CME now, it has to be graded. The continuing medical education has to be graded in terms of what component of that is actually related to patient safety. And so sometimes it's zero, like if it's a course, if you go to a national meeting, in other words, and you have a course that you go to, and it's a course on business, you're not going to get any, or practice management, you're really not going to get any patient safety CME for that. But if it's on something like, say for instance, we had one on preventing fires in the operating room, that essentially all of that would be related to patient safety. So each one is graded and coded, so that if you spend a whole day, you may spend 8 hours in a meeting, and you may get 1.25 patient safety credits or something along those lines. So anyway, it's something that, at least the difference from in the time that I've been in practice, is that it's really interesting to see, at least it's now on the forefront of everybody's mind, that it's important to really talk about and have a conversation about patient safety. A lot of that's come out of the Institute of Medicine guidelines from 1999. Some of you may know that or not, but it's basically has to do with To Err is Human. It's a very well-known publication about patient safety and public health when it comes to medicine. And we can talk about that more later if you like. So anyway, that's where we're at with patient safety and the quality initiatives. I spelled that wrong. It's the Medicare, the CLABSI. It should be CLABSI, which means central line associated bloodstream infections, and CAUTI, or catheter associated urinary tract infections, are two of the things that they're really looking at tracking. A lot of that doesn't have to do a lot with plastic surgery, but as you'll see later, some of the operations we do are really big operations. They're trauma cases. There are other things that we're involved with. So even if we're not primarily the physicians on those cases, we still have a say in these kind of things too. So it's important for us to keep track of that as well. Of course, mortality and length of stay is important also. We talked about the board certification, no longer having lifetime certificates and maintenance requirements. And also there's TOPS, which is also another initiative that plastic surgery has. TOPS stands for Tracking Outcomes in Plastic Surgery, and it's a database that we use as practicing physicians give the specialty national data. So all the plastic surgeons can submit data to this, and it's like having an ongoing database, which is where we get most of the cosmetic surgery numbers from, and some of the other like breast reconstruction numbers in terms of numbers of procedures done per year and those kind of things. It comes out of that information. So this is the disclaimer part I was telling you about. So after this, I just kind of want to give you a kind of a broad idea of what we do as plastic surgeons and what it means, and what kind of actual procedures we do, because it's not all just lumps and bumps or facelifts. So anyway, to get started, cosmetic surgery is one area, and we do facelifts, rhinoplasties, breast surgery, which includes augmentation, reduction, breast lifts, all of those different things, rhinoplasties, blepharoplasties, and then we have weight loss, skin reduction as well. And also, we spend a fair amount of time doing fillers, Botox, and lasers, and the fillers being the fine line fillers and those kind of things. I have a whole nother talk on that. Frankly, it was funny because we had somebody coming in. We had a visiting physician come in who does a lot of fillers and Botox to kind of train us on on one of the new fillers, and she's actually an internist, and she's really very good at what she does. And it was kind of interesting because she's right. She hit the nail on the head. She's like, you plastic surgeons, you guys just want to operate. You don't want to do this kind of fine little filler, touch up little things like this. And I had to give it to her. She was absolutely right. It's not been our focus of practice. So it's almost something that we do more or less because we have to in the cosmetic world because it actually is a really nice adjunct to what we're doing in terms of surgery also, but it's also one of those things that just to have people come in for non-operative care, it gets old to a plastic surgeon over time, but we're just used to doing bigger things, I think. This example of a rhinoplasty that we did a few years ago. So she had a really large dorsal hump here, and you can't really see it as much on the profile, but the tip's down a little bit and really narrow, and here's the deformity in the middle here, and pretty unhappy, but here she's a little better, so it's not quite such a downturn, but she's really happy here with the dorsal profile look. So this basically is it's basically just taking out the cartilaginous and bony septum and then infracturing things. So this is a baby that has cranial deformity, and this is I actually don't do these operations. This requires additional training. One of my chief residents a few years ago, Dr. Mancho, went out and did a craniofacial fellowship at Los Angeles Children's Hospital and came back. So he's now in Dayton. He's in his third year of practice now. And so he's gotten these more and more of these cases. So this doesn't really show up too well, but this side is pretty flat. This side is really bossing out. You can see how there's an angle here in the baby's head. And so they make an incision across the top of the head and basically peel all that skin down and take the entire bone off. They have to. The idea here is they want to remodel all of that bone. And what happens is the suture lines fuse too early in certain areas, and so this is pretty major surgery here. But baby did a lot better. It looks a lot better, and they have pretty nice results with that. But that's a whole nother year of training beyond what you do for our typical plastic surgery training. So he spent some time with some pretty well-known people out in California, and he came back and brought these services back to Dayton. And then here's another one of his cases, another cleft lip case, and then brought it back together really nicely. One of the things to keep in mind here is one of the things that you see, and this baby probably will have to come back for a little surgery on the opposite side, but you can see how he does, not only do they do the cleft lip at this time, but they also reshape the nose. And so his nostril looks a lot better even in the opposite side. So it's really a pretty neat thing that they do with the cleft lip and palate. But he's, like I said, he spends at least half of his time over at Children's doing the babies over there. So here's an example of a little skin cancer. This patient had all this done in a dermatologist's office. I was on vacation and they came back to show me he had a dressing on his head, and he says, yeah, we've got and very frequently the dermatologists will refer over what they call Mohs operations, where they do little things where they take a little bit of skin out at a time, and usually we have a little hole like maybe that big, and we do a little tiny local flap in the office under local anesthesia. And so we say, well, my nurse says, oh, you have a Mohs case. Didn't warn me or anything like that, and I walk in, take the dressing off, and this is what we're looking at. So it took him 4 days to do this, which in surgery would probably take us about 20 minutes, but anyway, he shows up with this. And so we ended up having to do an operation with microsurgery where we take the latissimus muscle from the back, connect it into the carotid artery and the jugular vein, and then put it on top of the head and then skin graft everything. So worked out well for him. He's doing well and moved on. But this is a basal cell skin cancer. So basal cells, this is one of the examples of, there's different types of skin cancer. So there's basal cell, squamous cell, melanoma. Melanoma tends to spread throughout the body. Squamous cell usually doesn't, it's kind of in the middle. But basal cell can be, it doesn't spread, so he's going to live a normal lifespan with this. But what ends up happening is that they end up, it can spread in over large distances. So it can really create big defects when you have a basal cell. So this is an example of why not to let your basal cell, if you have one, just leave it alone, so to speak. This is one of the most interesting cases I ever had. So this fellow was treated actually down in Cincinnati, and he came into my office with, he had been wearing a mask literally for years, a couple of years after this. He had a tonsillar cancer initially, and then to take the tonsillar cancer out, it's pretty common to do what we call a lip splitting operation, and they cut the mandible in half and then spread things open to get to the back of the throat where they can take out the tonsillar cancer. Well, that did okay initially, except for they radiated it, and his mandible basically fell apart where they had cut it. And then his tongue split right out through the lip. So he was drooling, he couldn't eat, couldn't do anything like that. So we ended up doing an operation. Now this tissue is from the back, again, one of latissimus muscle, but there's an artery that is up in the axilla that actually feeds not only the muscle, but it also feeds part of the scapular bone. And we took that scapular bone to reconstruct the jaw and released his neck contracture and put that in tissue to fill in the neck. So this skin here is here, and this is what we call microsurgery, and we do all this under a microscope, where we reconnect this little clamp right here is on the artery and the vein, and that's what we reconnect to give circulation through all this tissue. And he was extremely happy afterwards just to be able to eat again. Another leg, this is a motor vehicle crash. I'll move past that quickly. But this is an example when they have a motor vehicle crash, sometimes the bone is so damaged they just have to take out a portion of the bone. And so this is kind of something relatively new, although actually this case is, I think we did this case back in 2006. But they cut out 10 centimeters of the tibia in this situation. They put a frame on, this is an orthopedic surgeon to do this, and they do a thing called distraction osteogenesis, where what they actually do is they make another cut up here, and then they have the frame brings the bone back down. And as it goes so slowly, new bone grows right behind it as they go down. So it actually fills in all of this area. So because of the hole there, we had to put a flap over to cover this area, and it looks something like this. For a while there, it was really swollen. The problem with these frames is that you cannot compress the leg. So you have to wait till the frame comes off before you can compress it to get the swelling to come down. But after about 18 months, he has this result, and he's walking normally despite having all that done. So it was pretty good. There's another one. This guy got his toe run over by a lawnmower, and you can't see it here. What you can't see here is this extensor tendon to the toe is missing. Now, normally what we do in this situation is something pretty simple, and that's just we take the rest of the bone out, take the skin that's here and fold it back onto here and just leave him without a toe. This guy was adamant that he wanted to have this toe. He was like, I want my toe no matter what, you know. And I said, well, you have no tendon, and it's not going to work so well. But anyway, so we came up with an operation where we used his forearm skin and connective tissue along with the radial artery that's there. And then what we did was we left one of the tendons, the palmaris longus tendon, And this button here is where the tendon comes out, is wired through and back into the bone. And then we brought this this flap over here. Now, do they have a video? Do we have a place where I can hit the video button on this? Do you know? Do you have it plugged in back there? Where's the PowerPoint? Is it on here? If we can, let's see. Does it do anything? No. Should be able to click on. I had a video loaded up here, but since I copied it over, I don't know if it's going to work or not. Anyway, the video, maybe I can show you some other time on my computer, but the video shows that he's got full extension and motion of his toe. So it was really good. Now, what's interesting about this, not interesting to you guys probably, but I'll tell you the story anyway. We have one of the orthopedic surgeons that I work with has been there. Dr. Binsky has been in the department for, I don't know, 40 years or something like that. He's very well known nationally. Very grumpy guy, though. And so I was all excited about this case, you know. And I go up to him and I said, look at this video, look at it, look at how good this is. And he just goes, oh, and that was it. That's all I got out of him after all that work. So it was, you know, but still. So we do hand surgery. This is just somebody with a cut median nerve, and we put all the fascicles back together again. So that's another thing. A couple of our residents are now coming back. The chief resident from the last 2 years, one came back and joined the hand group here, and the other's going to come back and join us. And they both have hand fellowships. So we're looking at doing more replantation surgery and those kind of things in our group as well. So that's all I have. That kind of, hopefully, I hope I didn't gross you out too much, but that gives you, I think, a good overview of what plastic surgery is about. And I'll be happy to entertain any questions that you have. Sure.
You talked about board certification. Are there any other certifications above board, like diplomat, or I think it used to be?
So if you receive your board certifications, you're technically a diplomat of the board.
I wasn't sure.
Right.
Yeah, okay.
So there's a few other things that you have. So like hand surgery, for instance. There is what we call a certificate of added qualifications. So that's the step for somebody that has board certification. Now you can't get an certificate of added qualifications unless you're board certified in a primary specialty. So like for instance, the people that have a certificate of added qualifications in hand surgery, they can be board certified in orthopedic surgery, general surgery, or plastic surgery. All three of those boards feed into the certificate of added qualifications. So you just have to complete your boards in one of those three specialties.
Okay.
And then there's one so in terms of recognized fellowships, and in plastic surgery, there's the craniofacial fellowships and the hand fellowships. Those are the ones that have actual matches. And there's also fellowships in burn surgery, burn and critical care, microsurgery, and then there's also some in aesthetics as well.
But there's not a rating system like, say, Attorney Smart, you know.
Right. No, there's not a rating system for those three. There's just, well, there is actually for burn and critical care. That's a separate one, but not necessarily for burns or for aesthetics. Those are kind of most of the aesthetics ones. You have to kind of say, well, where did they train from? And usually the aesthetic ones, you're usually it's more of an apprenticeship type thing where you go with some well-known person, you learn how they do what their technique is and those kind of things, and then you move on. With the exception of, there's a couple of exceptions. One of them, especially the one at Manhattan Eye and Ear, which is an incredible fellowship that they get a lot of experience with a lot of different people. But that's one of the few that's in the country like that. Claire, you got to have a question. Or did you already knew all this stuff?
Yeah, a lot of this interesting. I guess, well, with Dr. Mancha's practice, because he's the craniofacial specialist, so you said about half of his practice he spends at Dayton Children's. What's the other half of his practice?
So the other half, we share call. So we share call and we share, oh, I'm sorry. The question was, The question was, what is Dr. Mancho's practice? He's half-time at Children's. What's the other half? So the answer to that is that because he and I share call, we get cases out of the emergency room, and so we really pretty much share everything. He does. So we share cosmetic patients that come in. If different referrals that come in, or people that need fillers. We both cover a little medical spa down south and do that. He'll do pretty much everything though, because I trained him, so everything else, with the exception of the craniofacial stuff, we do the same things. So microsurgery, hand surgery, breast surgery, whatever, just does all general plastics pretty much.
How does plastic surgery fit in with orthopedic surgery?
Well, how does plastic surgery fit in with orthopedic surgery, right? So I think it's a very complementary specialty to orthopedic surgery. Of course, orthopedics has their niche in terms of, obviously, they're more primarily into the treatment of bones, and they'll do hip replacements, knee replacements, those kind of things, as well as major fracture repair. And the overlap comes usually in the hand upper extremity area. So orthopedics and plastics both feed into the hand aspect of it. So most of what I do, I'd say a lot of what I do has to do with working with my orthopedic colleagues to give them soft tissue coverage over traumatic fractures, sort of like what we saw in the one case. But then there's a lot of different ways of providing that kind of soft tissue coverage in trauma. And so I probably have more experience with that than most plastic surgeons do, just because I've got 10 orthopedic partners that feed cases over to us. Yeah.
It seems like in California, there's a lot more plastic surgery done for cosmetic reasons. And some of the jobs I've seen have been amazing.
Mm-hmm.
And, like where my sister went, sometimes you have to wait quite a while to get in, or like in Ohio, do most of the doctors' wives and family members have it? It seems like in California it's so much more prevalent.
So
I've
the
just seen-
question was about plastic surgery in California. I think it's probably a cultural thing. And every region has their own sort of culture and the way people think, and that it's basically social, That's the best way I can explain it. One of our residents went to California, and he went to a hospital that has 74 plastic surgeons on their staff. I mean, they have more plastic surgeons on their staff than general surgeons
And
on their staff.
you can't just walk, some of them you have to wait a long time. You just can't walk in and say, hey, I want this done,
Well,
yeah.
I think that depends on the practice and the individual,
I
and
mean, facelifts, yeah.
and I think they become famous, so to speak, in New York City.
Not necessarily better, but yeah, some of them just famous, yeah.
Yeah, I mean it's more famous, and they've been in practice for a while, and they ramp things up. There's a couple of plastic surgeons in New York City that charge $25,000 for a facelift, and they have a waiting list. I mean, that would never happen in Dayton, Ohio, but in New York City, that's not that uncommon.
I think yeah.
So I mean, it
I actually
varies.
thought it'd be more in New York City, actually.
Well, that's
Yeah.
their surgeon's fee. That's not including
But then
anything
you have
else.
to include the hospital and everything else, yeah. So it could be,
Yeah.
you're talking big money then.
Yeah, for a 3-hour operation, that's not a bad gig if you can get it.
So then
Yeah.
by the hospital, it could be probably, what, 100 or something?
Well, I guess it depends. Some facelifts are done just in the office, though. I mean, a fair number of facelifts can be done under local
yeah.
anesthesia in the office. Depends upon the technique, depends upon the patient's desire for anesthesia or not, and their ability to tolerate just local anesthesia and with some little oral sedation, or whether or not they can want full general anesthesia.
In your opinion, what is the future of the plastic surgery?
Well, I think the future of plastic surgery is probably going to, because as you can see, we don't just do cosmetic surgery. It's really a thing of what's the future of medicine, I think, is the better question. The question was, again, to repeat, what's the future of plastic surgery? I think it's really interesting right now. There's going to be a transition in all medical specialties about going from volume-based care to value-based care, and what does that really mean, and how is that going to affect things going forward in the future. I think that plastic surgery is really, I wouldn't say every plastic surgeon, but there's very few plastic surgeons that are not integrally involved with the medical community. There's a few, like in California and some other places, that do just cosmetic surgery, 100% cosmetic surgery, but that's pretty rare around here, and pretty rare nationwide, actually. If you look at most of the people, most of the plastic surgeons that I'm training, and the groups that they're joining, most of them, like our group, does a mix of everything. And so,
you would want to.
yeah.
I mean, that's,
Well, I mean, there's advantages and disadvantages. I mean, for people that just look at it from a money standpoint,
standpoint,
you know, then you're kind of looking at, you know, maybe trying to do cosmetic surgery all the time. But most of us didn't get into it just for the money. I mean, there's always a few in every specialty, but, you know, I think that the biggest thing is really what's going to happen to medicine in general. And I'm taking public health classes right now just to try to figure that out. In other words, what do they mean by value? And value, I think, really comes down to what's an outcome that matters to the patient, you know, and how do you value that, and how much is that worth? And if you think about it, the system that we have now doesn't make a whole lot of sense, and how it came to be doesn't really make a whole lot of sense, because if you look at it from a public health viewpoint, why is it that certain specialties like orthopedics, ophthalmology, and plastic surgery, to some degree anyway, make a lot more money than the general internist who's out there managing some hypertension that's keeping somebody from having a stroke and dying every day? You know, I mean,
the other would be harder to.
right? I
was
mean,
what
well,
I'm talking about being an eye surgeon.
well, there's more training involved, and I guess it's because some of it is because it's a very specialty oriented thing. Just like some of the things that I do, not everybody can do. I'll be honest with you.
Sure,
I mean,
that's what
the microsurgery part of it, even there's not all the plastic surgeons. In fact, I'm myself and Dr. Mancho and maybe one other person are the only people that really do microsurgery on a regular basis. You know, because it's just something that is technical. So for that,
God-given hands too.
well, for that reason, I mean. And that's not to sound conceited or anything, but it's just that there are certain specialties where it does take a long time to train, and does take all that, and so that
Brain
probably
power. Yeah, I mean,
that should be compensated, but it's more draining. Especially think about a psychiatrist. I mean, a psychiatrist who has to go in and try to work through people's psychological problems all the time. That's emotionally draining. That's even more draining than the physical aspect of doing surgery. I mean, if I had to do that every day, I think you'd have to pay me a lot more now than to do surgery, just to listen to people's problems all the time. But that's what really matters if you think about it, because the thing about health in general, there's so many psychosocial determinants to health that that's really what matters. And if you think about it, most of what we do, even with cosmetic surgery, if you look at cosmetic surgery in and of itself, yes, there's physical benefits that you can see.
Like buying a pretty clothes.
But it's like, how does it make somebody feel? How does it make you feel about yourself? That's what really matters. Breast reconstruction is a psychological operation. Mm-hmm. I mean, to give somebody who has no breasts a normal appearance and normal things like that, it improves their psychology tremendously. And that's what it's all about. It's how do you make people feel better about themselves? And can you contribute to that? And if we can do that, then the future of plastic surgery is pretty bright. If we lose sight of that, I think we're in trouble. But medicine's in trouble in general if we lose sight of that. It's clear.
So you mentioned how there's kind of these regional trends, like in California there's a lot more cosmetic surgery. How do you think that impacts the training of residents based on where they choose their residencies?
So the question is how does, with regional differences in practices, how does that affect where residents choose to train, or how does it affect their training?
Their training.
So the answer is it doesn't really affect their training at all in terms of the core plastic surgery board certification process. And the reason for that is because the training is fairly well set in stone almost. In fact, set in milestones now to say that, because now we have to do, as you'll find out next year, the residents, we're required as faculty fill out milestone evaluations on the residents to make sure that they're progressing through as they're supposed to in all the core areas. So, and that's going to be publicly reported stuff, I believe, from the ACGME. So part of that comes from the public demanding, if Medicare is going to pay for graduate medical education, that they want to see documentation that things are actually happening. And so that has a lot to do with this milestone project. But the number of, just because you train in California or if you train in other places, you still have to have the same index requirements of different operations. There's minimum operative logs that you have to complete before you can graduate. So, you know, that's a given. So it doesn't change just because somebody's in California. They don't say, oh, you get to do more cosmetic cases and fewer reconstructive cases, or vice versa. We all have to do the same amount no matter where we train. Yes?
So based on the cases you showed us, it seems like plastic surgery has a wide variety of procedures and such. So would you say that plastic surgery allows you more of a liberty in surgical approach as opposed to other surgical specialties?
The question is about liberty and surgical approach in plastic surgery. I think it's one of those, the answer is yes, in short. I think what you're getting at is there an artistic part to plastic surgery? Is there freedom of how you do things and stuff like that? The answer is that it's all about the outcome, but there are very specific steps in any operation, understanding the anatomy, understanding where blood supply is, and some things like that really aren't necessarily freedom to do stuff. That's what guides you through a safe operation. So it's learning those things. When it comes down to even a rhinoplasty, for instance, there are certain guidelines that we have about how much can you reduce the dorsum before you have to break the nose and do an infracture. When do you use cartilage grafts? When do you not use cartilage grafts? These kind of things. It all has to do with the anatomy and understanding that, and that's part of the training process. That having been said, there are a lot of different ways of skinning a cat. For instance, when you have, when you have a hole, we can do a rotation flap, we can do a transposition flap, we can do a skin graft. There's different options sometimes that you have, and then you have to kind of match up what you believe the best option is going to be for that patient to give them the best outcome. So that's what's kind of fun. I like those kind of things where there's several different options, and then it's like, then you start splitting hairs about which one might be better and why. And then that's when I'm talking to my residents, working through the process. It's like, okay, this is why we're going to do it this way because,
Seems like
we think
it's
it's
so
gonna be
stressful.
The question is about stress. I think that's an interesting question.
To do it, yeah.
Well, I think that's an interesting question. I think, and that's one of the things that I think we'll know more about whether the integrated programs are better than the independent programs in a few more years. Because in terms of stress, there's nothing that I've done in plastic surgery that was more stressful than taking care of dying trauma patients that are in the emergency room. That's stressful. When you're in plastic surgery, you don't really get, so in other words, when you've completed general surgery, you've gone through the most stress I think that you could possibly imagine. When you do trauma and you do big tumor operations and you deal with big vascular procedures and those kind of things. So what's going to be interesting is there's a whole other generation of plastic surgeons that are being trained that never had that kind of stress because they're going straight through plastic surgery. So there's going to be an interesting thing as we go forward about, is there going to be a big difference between the two kind of cohorts of plastic surgeons and how they were preliminarily trained? did they go through general surgery or not, and is that going to make a difference?
I think I'd want the general surgery, but for the patient.
Well, there's advantages and disadvantages to both. I mean, what we've seen so far is that there hasn't been too much of a difference, and you're right in thinking that having somebody that's gone through that stress, but that's sort of the training part of it and the life experience part of it. The thing is that what we found is that because plastic surgery is so competitive right out of medical school, that we're getting the top of the top. So you're getting superior applicants into your pool. Whereas the general surgery applicants, the ones that are going through general surgery, typically, it's not that they're bad, they passed all the stuff, but they're not been the top of the class. So you got the top of the class that's training shorter, and then you got people that are maybe in the middle of the class that didn't quite make it into plastic surgery initially, that are then going through general surgery and then working their way up to take a couple extra years to do it. I don't know that there's going to be a big difference between the two groups, but it's kind of interesting, and then we'll see. But in terms of board certification, being able to pass the boards and everything, there hasn't been any difference between the two. They both end up passing. So, but it's just different pathways. One is a little more intensive training, a little longer training, and the other is starting out with maybe a better qualified cohort as on the entrance level. I guess that's the best way I could put it, if that makes any sense.
Dr. Johnson, what's the best way to research plastic surgeons? Find the right one for what we want.
That's a really good question. I think, first of all, you have to make sure that you have a plastic surgeon, because there's a lot of people out there that are. The question is how do you find a plastic surgeon? How do you research?
I can give you a degree here.
And this is, when I talked about earlier, your question about the future of plastic surgery and how it fits into the medical community. Unfortunately, what's the downside of internists and family docs being underpaid, in my opinion, what's happened is that they've tried to make up for that in terms of doing either cosmetic surgery, fillers, Botox, things that they weren't really trained to do. And you see that occasionally, and there's no law against it. If they have a plastic surgery, or if they have a medical license and they're practicing in their own office, in other words, they can, and it's amazing what people will do in their office, but they'll do, facelifts and unaccredited things, all kinds of things, liposuction, that kind of stuff. But if you're in your own office, it's let the buyer beware from the medical board standpoint. So you have to make sure that initially that they are board certified by the American Board of Plastic Surgery. Now, is that enough? Probably not. You probably need to do some more research on top of that. And the most important question is what's the doctor's experience level? I mean, what are they comfortable doing, and what are they not? And frankly, most of the time that comes from the face-to-face interview, unfortunately. I mean, you can look online, you can look at health grades and those kind of things. I think a lot of people are starting out with that now, and just to see what other people have talked about in that situation, and seeing, that kind of thing. And that's becoming probably more of a focus for plastic surgeons too, is to look at their online reputation and that kind of stuff, because that's where virtually everybody's starting out. And I think that's a pretty good place for everybody to start too. I don't really have a problem with that at all. Because if you're people, unfortunately, it's like everything. If you have a bad outcome, people, you may have. If you have a bad, it's like the old saying, if you have a bad outcome, they're going to tell everybody. If you have a good outcome, they may tell one or two of their closest friends, but they may not put it out there for everybody to see. But so you have to be a little careful on how you. But it's like every Better Business Bureau and those kind of things. You have to protect your online reputation too, as a practicing physician. So I think that's a good place to start. But make sure that they're a plastic surgeon. Make sure that they're board certified. That's the minimum things you should do. And then after that, it's basically, ask them their experience. Ask them how many they've done, what they've done, how many they've done, what kind of results they've had, and those kind of things. I hope this was helpful.
Interesting. I thought it was going to be on facelifts, but I'm thoroughly enjoying it.
Well, we can talk about facelifts too. But so talking about facelifts, what's interesting when you talk about there's been some good things on technique, but everybody will have their own technique, and sometimes it becomes about marketing. And if you look at the lifestyle lift company, which now just went out of business, it's kind of interesting. And I'm not saying that was a good or bad business, or I have no personal thing about that, but they were super marketers. I mean, when you market something like that, and that's unfortunately what cosmetic surgery frequently becomes about, whether it's hair transplant or results, the next day and stuff like that. It becomes much more about marketing than anything else, which is a little bit bothersome, but that's the name of the game, and that's why it's the patients have to be careful just about. And it could be that and we've had some very reputable plastic surgeons that were part of the lifestyle lift company, and so there's nothing necessarily inherently wrong with it, but it is something that you have to be careful, because you have to make sure you know who your surgeon is. I think that's the best way to decide. But yeah, there's a lot of different techniques, and none of them necessarily have been proven to be better than the other. In fact, there was a twin study where they looked at 2 sets of twins. They had 4 different very prominent plastic surgeons across the country operate on the 2 sets of twins, and they really didn't find any difference. And they all had very different techniques. Some were very deep plane techniques, some were more superficial, and they found that they really had pretty similar results. So it's more about the experience of the surgeon probably than it is about what individual technique is used. Because somebody may say, well, you got to do a subperiosteal lift or something like this, and they'll come up with some kind of thing. But it's about the experience of the surgeon, I think. All righty. Thanks, everybody. Thanks for coming. Spending your evening.